Good afternoon. My name is Kathy Allen-Bridson, and I'm here to present to you information regarding distinguishing primary from secondary bloodstream infections, or BSIs, for the NHSN National Patient Safety Component. We're going to review some important foundational concepts from Chapter 2 and Chapter 4 from the NHSN Patient Safety Component Manual. We're also going to identify the relationship between site-specific infections and secondary bloodstream infections. We'll also review Appendix B, which is the Secondary BSI guide found in the BSI or bloodstream infection protocol. And we'll reference some tables from that chapter as well. And then finally, as we're going along, and then at the end, we'll also have a chance to practice to applying some of the secondary BSI guidelines to some educational case studies. I'm going to pause slightly so that viewers can pause their own video before I provide answers to the questions and case studies. So if you are interested in trying to formulate an answer and see how well you understand the information, that's your opportunity to just pause the video, and then once you've made a determination, to go ahead and start the video again. So first of all, let's do some basic definitions, and the very important one that we need to make distinguish between our primary and secondary BSIs. And simply put, a primary BSI for NHSN purposes is a laboratory-confirmed bloodstream infection, or LCBI, where an eligible BSI organism is identified in the blood, and the BSI is not secondary to a site-specific infection at another body site. And what do we mean by secondary? Well, for a secondary BSI, we mean that BSI is associated with a site-specific infection at another body site, and it could have seeded the bloodstream. And we'll talk about very specific scenarios that allow you to determine that the BSI is in fact associated with another site of infection. Specifically, where this information is contained in the BSI definition is the line that says that organisms identified in the blood cannot be related to infections at another site. If they are, then we would consider those to be secondary. And for NHSN purposes, LCBIs need to be primary in nature, and that's because we use that data to inform prevention efforts aimed at bloodstream infections. Those prevention efforts are not aimed at second or other primary sites of infection, because there are a lot of other potential primary sites of infections, but for the most part, we're interested in central line associated bloodstream infections, and so we want to make sure that there's a good chance that infection prevention practices related to central lines can impact the BSI rate or SIR. So here's our first question. Why is it important to distinguish a primary BSI from a secondary BSI when performing CLABSI surveillance? The choices are that the secondary BSIs are not reported to NHSN, that primary BSIs are more difficult to prevent than secondary BSIs, or C, that to identify those BSIs for which performing central line insertion and maintenance practices may reduce the incidence. And here is the first example of where I'll pause so that you can pause the video if you want to formulate an answer, and then you can turn it back on. So the correct answer here is C, as we just discussed. These are the bloodstream infections that we're trying to identify with our LCBI definition, are those that, and especially with our CLABSI definition, are those that by improving our central line insertion practices or even our maintenance practices for central lines, we can reduce the incidence of CLABSI. Secondary BSIs are never reported to NHSN as LCBIs. They can be reported and should be reported if you're reporting the primary site of infection. So for instance, if you have a urinary tract infection with a secondary BSI that you're reporting to NHSN, you would include information about the secondary BSI. And there really are four types of infections that a BSI could be secondary to an NHSN. They could be secondary to urinary tract infections, to pneumonias, to surgical site infections, or to one of the infection types that are listed in the CDC's NHSN surveillance definitions for specific types of infections. And that's also known as Chapter 17 in our NHSN manual. That site, if you're not familiar with it, has all of the various types of infections that can occur in a patient. For instance, cardiovascular infections, such as vascular infections or meningitis, bone infections, just to name a few. And we really have just two scenarios in which a BSI could be deemed to be secondary to another site of infection. Scenario one, which we're going to talk about first, and we'll talk pretty in depth about both of these types of scenarios. Scenario one involves a matching site-specific specimen. And when we say matching, we mean that it matches an organism identified in the blood, and that site-specific specimen is an element of the infection criterion for this specific type of infection. In scenario two, an organism is actually identified in the blood, and that positive blood specimen is used itself as an element of the infection criterion. So again, there's two and only two secondary BSI scenarios. There is a little bit more information that we should share about both of the scenarios, some time periods that go along with it. So for scenario one, where we have at least one organism from the blood specimen that matches an organism identified from the site-specific infection, that has to be collected during the secondary BSI attribution period. As we also call that the SBAP. And the SBAP is, as you may know from previous presentations, the infection window period plus the repeat infection time frame. In scenario two, where you're actually using a positive blood specimen to meet one of the elements, because that blood specimen is an element of the criterion, it has to be collected during the site-specific infection window period. So let's talk a little bit more about scenario one first. So there really are three must-haves for BSI scenario one for secondary. That is that the blood and the site-specific specimen must have at least one eligible matching pathogen. Now, it is possible that the blood specimen may have other organisms that are not identified from the site-specific specimen, and that's okay. We would consider the whole blood specimen to be secondary if all of the criteria are met, including the non-matching organisms. The blood specimen is used as an element to meet the primary infection criterion. And the blood specimen is collected within the SBAP of the site-specific infection. And I'm reading that there's a typo on here. It should say that the site-specific specimen is used as an element to meet the primary infections criterion. So please make a note of that on your slides. Number two is the site-specific specimen. So, for instance, if you are meeting a urinary tract infection criterion, the urine culture that matches the blood culture or blood specimen would have to be used as an element of the UTI definition, which UTI does have a criterion. All criterions require a primary or a positive urine culture. There is an important point to follow that up with. If an organism in the blood is ineligible for the specific infection type, then that organism cannot be considered to be caused by or secondary to that type of infection. So again, falling back on the UTI example, we have one here. Candida are excluded pathogens that cannot be used to meet the NHSN UTI definition. Candida in the urine is usually accepted to be not necessarily a cause of infection, but oftentimes colonization in patients unless they're severely immunocompromised. And for that reason, among others, it's an excluded pathogen for UTI. So therefore, if a patient has a UTI and the only organism is Candida, then the patient actually will not meet the UTI definition, and therefore there could not be a secondary BSI to UTI with Candida. Pneumonia also has some excluded pathogens, so those are the two main types of infections where we'll run into that. So unless there is another source of infection for that Candida in the blood, it's possible that the patient may have a primary BSI. So let's look at another example. We have a patient that was admitted, and this is actually speaks to this point, a patient that was admitted on the 12th of January with a chronic history of sinusitis, submitted to the medical surgical unit. And on the 15th, the patient is sent to special procedures unit for functional endoscopic sinus evaluation, and they aspirate fluid from the sinus cavity and send it for culture, and the results are that it's positive for strep pneumoniae. 119, the patient is febrile to 102 Fahrenheit, and they draw a blood specimen and culture that, and the patient is also positive for the same organism, strep pneumo, in the blood. So in this case, we have a positive specimen in the sinus fluid that matches, and that organism is eligible for sinus infection, and it matches at least one organism in the blood, in this case, the only organism. The blood is collected in the secondary BSI attribution period, and that sinus fluid culture is actually used as an element to meet the site-specific definition. So I have a graphic of that in the next slide. So you can see that in this case, we have the patient has met the criteria for sinus infection or sinusitis. Criterion 1, which really only requires that there's an organism identified from the fluid or tissue of the sinus cavity, that occurred on 1/15, and the patient at that point meets the criteria, and so this is considered a healthcare-associated sinusitis just based on the date of admission of 1/12, and that this is on hospital day 4, so this becomes an HAI. And then as you can see on the right-hand side, we have outlined both repeat infection time frame for you, as well as a secondary BSI attribution period. And the secondary BSI attribution period, or SBAP, involves both the infection window period, which is in green here, and the repeat infection time frame, or RIT. And during that SBAP, a blood culture is collected that has a matching organism to the site-specific infection that was used to meet the sinusitis definition. So in this case, the patient has a healthcare-associated sinusitis with a date of event on 1/15 with strep pneumo and also a secondary BSI with the same organism. So I have a question. Must the Staph aureus be investigated in this case as a potential LCBI or CLABSI? So in this case that we have here, this very brief information, which is something that you might see. In some cases, infection preventionists will see that a patient is admitted, in this case, for instance, on 1/12 is admitted with a positive blood culture for E. coli, and they don't necessarily work that up because it's clear that the patient came in with that. But then if there's a second blood culture collected on 1/22, 10 days later, that's positive with a different organism, in this case Staph aureus, what happens then? Does the IP need to work that up, or does the IP just simply say, well, it was during the repeat infection time frame for the bloodstream infection, so it doesn't have to be investigated? It's really important to remember that a positive blood culture on admission doesn't necessarily set a BSI RIT, and that's because the blood culture might be representing a secondary BSI, and only primary bloodstream infections set a bloodstream infection RIT. Secondary bloodstream infections actually don't set an RIT, but an RIT would be set for the primary type of infection. So it would be necessary in this case to determine if the E. coli was primary or secondary to another site of infection, to then determine if the Staph aureus BSI needed to be investigated as a possible LCBI and also possibly as a CLABSI. So let's look at a schematic of this. As you can see, patient was admitted on 112 and at that time had a positive blood culture, but the patient also had a positive urine culture and a fever. This is a 55-year-old patient, so even though there's no Foley present, a fever can be used in the UTI criteria. Patient actually meets the UTI criteria on that date with fever and positive urine culture of greater than 100,000 of E. coli. And so this is a UTI that's present on admission, and in this case the patient has a secondary BSI related to that. They have a matching organism for both the blood and the urine. A UTI repeat infection time frame is set, as is noted here, 14 days. But what is not set is a BSI RIT, because this is a secondary BSI. So date of event for the SUTI 1B, which is a non-catheter associated UTI, is 112, and there's a secondary E. coli BSI. But you'll notice that on 122, the patient has a positive blood culture also collected. I'm noting that it says 122 on here, in here, but it's actually been checked as 121. So we'll go with the 121. In this case, that Staph aureus, because it does not match the organism in UTI criteria in the urine culture, has to be investigated. So if no other type of infection is identified to which it could be attributed, that would have to be considered a primary BSI, and it could be potentially be a CLABSI. So it's important not to simply assume that because a patient comes in with a positive blood culture that a BSI RIT is set. If no subsequent blood cultures are collected, then it's possible that no investigation of that original BSI would be necessary. But if another blood culture is collected that has a different organism, then it may be that you need to investigate that first BSI. So let's talk about secondary bloodstream infections in scenario 2. And this is the scenario whereby you're actually using the positive blood specimen as an element to meet the NHSN site-specific infection criterion. And it's collected during the site-specific infection window period because it is an element. So there's really two must-haves. The blood positive organism has to be used as an element to meet the infection criterion, and it has to be collected during the infection window period, or in the case of a surgical site infection during the surveillance period for SSIs. So let's look at an example of this. In this case, we have a patient that's admitted again on 112. And the patient was the victim of a fireworks accident and had first and second degree burns to the right hand. The wound assessment on that day showed that the patient had pale pink to red, glistening, mild swelling with small blisters between the fingers. 3 days later, a wound assessment showed a marked increase in swelling of fingers, purplish eschar with right index fingertip noted to be black. And 3 days after that, the patient is running a fever of 101 and has a blood specimen collected, actually 2 of them that are positive for Pseudomonas aeruginosa. So in this case, the patient actually meets the burn criteria. They had criterion 1, patient has a change in the burn wound appearance or character. They give some examples such as rapid Eschar separation, which we don't have, but we do have the violaceous discoloration of the Eschar. And there is an organism identified from the blood. Since the blood culture is the diagnostic test in this case, and that is used to set the infection window period on 1/18, and then the 3 days before that and the 3 days after make up the infection window period. And as you can see, the first element of the infection criterion was met on 1/15. And so since this patient came in more than 2 days before, so on day 3 or after, it is considered a healthcare associated infection. And in this case, this patient has a burn infection, HAI, with Pseudomonas aeruginosa. Date of event is 1/15, and the patient has a secondary BSI. So, your next question is, what if neither scenario 1 nor scenario 2 can be met? The choices are that no event is identified, that it represents a primary BSI, or that C, you should email NHSN for guidance. And I'll pause. The correct answer is that it would be a primary BSI. Now, you can always email NHSN for guidance, but our answer will be that if neither scenario 1 nor scenario 2 can be met, then it will be a primary BSI. So let's look at an example. In this case, on 1/15, the patient had a breast fluid collected during an invasive procedure that was positive for Staph aureus. And on the 18th, the patient had a fever of 100.6, had blood cultures ×2 positive for coag-negative staph. So in this case, the patient met the breast or mastitis infection criterion 1, organisms identified from affected breast tissue or fluid obtained by an invasive procedure. It was Staph aureus. The patient does not match scenario 1 nor scenario 2. He doesn't match scenario 1 because he doesn't have a specimen from the site of infection that matches the blood specimen. In this case, we had Staph aureus in the blood, at the site, and the patient had, had coag-negative staph from the blood cultures. So we don't have a match there. And there is no breast criterion that includes the identification of an organism from a blood specimen, and so therefore the patient does not meet scenario 2 either. And so this is actually a primary BSI for NHSN purposes. Now there is one exception. There's always one exception at least, isn't there, for everything. One exception to a patient meeting neither scenario 1 or 2, but being able to identify a BSI as secondary, and that's our necrotizing enterocolitis criteria. Our NEC criteria includes neither of the elements, a site-specific specimen or organism identified in the blood. Neither of those are used as part of the criteria, and so therefore we've made an accommodation. And the guidance is presented that if the patient meets one of the 2 NEC criteria and also has an organism in the blood that's collected during the SBAP, we'll consider that BSI secondary. Now, you'll see there's other information here that it has to be a recognized pathogen or 2 common commensals collected on separate occasions. And the reason for that is that we would just, before you called a BSI secondary, we would want to make sure that the patient actually met criteria for LCBI and all other variables. So if they had a single common commensal, you wouldn't call a secondary BSI. So we're going to talk a little bit about assigning pathogens in secondary BSIs. This can be somewhat a little bit confusing in some cases, but what we have done in writing these rules is to just try to have consistency in how we assign pathogens. And so if you always keep that in mind, that is helpful. So a couple of rules. An organism can be attributed as secondary to more than one type of infection. So you might have a patient that had met criteria for a UTI with E. coli and had a positive blood culture with E. coli, and also at the same time had an intra-abdominal infection that was identified, and they cultured E. coli from the intra-abdominal cavity, and the patient met criteria using that. So in that case, we would say that E. coli is actually it would simply be recorded as secondary to both. And that, again, that's just to be consistent. It's also possible that in scenario 1, there are additional organisms in the blood besides the one that matches the organism in the site-specific infection, and those additional organisms would also be considered secondary. Well, I'll show you a case to kind of flesh this out a little bit. But on the other hand, if there is no matching organism in the site-specific specimen or in the blood, if blood was used as an element earlier to meet the criteria, then the BSI cannot be considered secondary. So let's see what that looks like. So in this case, we have a 60-year-old patient that's admitted to the hospital with a fever of 101 Fahrenheit and has a central line and Foley both placed on 113. And then the next day, the patient has a urine culture collected, and it is final for greater than 100,000 colony-forming units per milliliter of E. coli. They remove the Foley. The next day, the patient complains of dysuria. The central line is removed, and positive blood cultures are growing E. coli. They were collected that day and are growing E. coli and E. fecalis. On the 16th and the 17th, the patient has 2 other blood cultures collected, each one growing E. fecalis and Staph aureus. So schematically, let's see how this looks. And for those of you that are not aware, this common format that I'm using is actually from our HAI and POA worksheet generator, which is online and which can help you to map out these different time frames. So I would encourage you all to look into that if you haven't done that yet. In this case, again, we had a patient admitted on 13th with a fever, and on the 14th, they did a urine culture that was positive for E. coli, meeting the requirements. And the patient also ended up having dysuria the next day. And this patient had also a blood culture collected on the 15th with E. coli and E. fecalis. So you'll note that the patient meets SUTI 1B criterion, a non-catheter associated UTI, with a date of 113, which makes it a present on admission infection. And because there is a matching organism, that E. coli, to both the urine culture used to meet the UTI definition and in the blood culture, that whole blood culture is going to be considered secondary to the UTI. So we would say it's a secondary BSI with E. coli and E. fecalis. But the patient then had a couple of more blood cultures that were collected. Each of the following days, the patient had blood cultures collected. containing no E. coli, but E. faecalis and Staph aureus on both days. So in this case, there was no Staph aureus in the original urine culture, nor in the previous blood culture, and there was no E. faecalis in the previous urine culture either. And remember that we said that there has to be a matching organism to the site-specific infection in order to say that the matching organism in the blood is secondary. So in this case, we needed to have an E. coli in the blood specimen, and we don't have that. So for that reason, if there are no other sources of infection to which this could be attributed, this is a primary LCBI1 with a date of event on 1/16, and both organisms are listed. The blood culture that's collected on the following day occurs in that BSI RIT. So a BSI RIT is set beginning on 1/16 and going through 1/29. That would be a BSI repeat infection time frame, and the second blood culture would not be recorded separately. So we're going to talk just a little bit, very briefly, about some tools that we have to make your life a little bit easier in making these determinations, some educational offerings that we have and references before we get into our case studies. And the first tool that I want to bring to your attention is Table B1 from the BSI protocol. And this table is the primary sites that are eligible for secondary BSIs. And you'll see that we have listed out, they're obviously shortened versions, but these are lists of all of the types of infection criterion, and whether or not they can be used to meet scenario 1 or scenario 2. So just in the little data that you have available to you, you'll see that for scenario 1, which again, remember, is that there's a matching organism in the site-specific specimen and the blood. We could say, oh, I have a blood culture, or I have a culture from a bone. I wonder if I can see if they meet scenario 1. I could look at this tool and see, yes, criterion 1 is the only criterion that would be available for me to meet the secondary BSI scenario. Likewise, I could say, oh, darn, I looked into it and the organism from the bone and the blood are not the same. I wonder if I could meet scenario 2. And then I could go to the scenario 2 column and say, oh, I could meet possibly criterion 3A. I need to go and look at criterion 3A and see if the patient meets those requirements. If they do, I may be able to say this is secondary. If they don't, then I know those are my only two options to say that this is secondary to the bone infection. And I would either have to find another site to which it could be attributed, or the BSI would be primary. So depending on your situation, this can be very helpful. Another tool that we have is for those people that are very kind of visually like to step down through a flow chart is this figure B1, also from the BSI chapter, which starts at the position that you have a positive blood specimen, and you suspect that there might be another source of infection to which it could be attributed. And it will then walk you down through a set of questions as to make a final determination of whether or not the BSI is primary or secondary. And you'll probably notice that what actually happens is that one arm of this flow chart here is actually scenario 1, and the other one is scenario 2. So if you don't meet 1, then you're going to end up having to go to 2 to see if that meets. And if the answer to no is both, you're going to wind up with a primary BSI determination. I want to ask you to keep your eyes open for some new training resources for BSI and secondary BSI in particular. This presentation will be posted to the NHSN website as soon as we have finished getting closed captioning done, and some other requirements that we have at the CDC. So hopefully in the next month or so, this one will be going up. And I would also tell you, I provided a couple of website URLs here. We actually have a quick learn video that is 9 minutes in length that is specifically for determining or distinguishing between primary and secondary BSI. So 9 minutes isn't hard to find in your day, and if you feel like you need a little bit more information, I would really encourage you to go and to look at that. Additionally, we have frequently asked questions, and when you log onto the BSI site, you'll find options for training, protocols, and then frequently asked questions. And when you choose that, you get a page that looks like this. And this is really nice now because we actually have the topics listed, and you can click on the topic and it'll take you right to that answer on the page. So you can see that we have site-specific criteria and secondary BSI. There's also a wealth of other information, and I would encourage you to take a peek at what's here. Lots of little tips that you can pick up, and something that you might not really understand that you have a misunderstanding about and you're not aware of it. So take a look. So we've covered all of the information that we needed to cover, and now we're going to get to the fun part, which is going over some case studies. And again, feel free to pause the video after the questions are asked and try to make a determination yourself, and then start the video again for the answer. So our first case study is a 35-year-old woman who was admitted on February 1st with complaints of right scapular pain and fever. She had a superficial laceration to her right scapula from falling into an outdoor grill 5 days earlier. Wound is scabbed over in places, but there is purulent drainage noted from the center. She is admitted for IV antibiotics. 2 days later, it's not really showing any improvement in her wound with the broad spectrum antibiotic coverage. It's swelling, it's red and warm to the touch, and some of the drainage is actually sent for culture, and it's positive for strep pyogenes. 5 days later, the patient's fever continues. This must be a tough bug. And the WBCs are continuing to increase, and they're now at 20,000 WBCs. Blood cultures are collected, and the final results are positive for ampicillin-resistant strep pyogenes. So, is this case study 1 a primary LCBI? Your choices are yes, this is a primary LCBI with strep pyogenes that's identified on hospital day 3, which is February 4th, or no, this is a primary skin infection with a secondary BSI. The correct answer is that this is a primary skin infection with a secondary BSI, and let's look at that in a little bit more information. The patient, as you can see, actually meets a couple of criterion for skin. Patient had purulent drainage from the site, which is enough to meet skin criterion 1. But the patient additionally had 2 of the following localized signs or symptoms: pain, swelling, erythema, and heat, and had an organism identified from aspirate or drainage from the affected site. And again, we're looking for those organisms that are pathogens, but there actually is some information, or common commensals, but there are some organisms that would not be considered eligible for use, and those are listed here. But for the sake of purposes for this case, we don't need to worry about those because we have strep pyogenes. And as you can see, We've taken a snippet from table B1, I believe it was, which is shows that there indeed is a scenario 1 option for skin, and that is criterion 2A, which we have met. But it's important to note that in cases like this, where there is more than one criterion that can be met, we want you to use the infection window period that provides the earliest date of event. And that's important, and it's actually in your favor to make sure that you do that, because it can be the difference between identifying an infection as present on admission or identifying it as a healthcare-associated infection. So again, patient met POA, skin 1, on the day of admission with the purulent drainage. So that would be the earliest date of event that you could use, and that would be to your benefit, obviously, to call that or to use that, that criterion, as opposed to criterion 2A, which was the skin culture with swelling, redness, and heat, and a positive blood culture, because if you used that, you would not have a date of event until 2-3, and that would actually be a healthcare-associated infection, so you wouldn't want to do that. So always use the earliest infection window period when you have a scenario like this. In this case, this is, however, a case of secondary BSI with multi-resistant strep pyogenes. So even though you have you've set a secondary BSI attribution period here and a repeat infection time frame, this 2A is occurring during the repeat infection time frame, and so that's why you can say that this is, it's all one event and it's secondary. Hopefully that makes good clinical sense as well. And really this just, again, drives home the fact that you would not want to use the wrong infection window period or the later infection window period and have to call this a healthcare-associated infection. So, let's look at a couple of other examples of meeting more than one criteria of the same type of infection. In this case, too, we have a 67-year-old female that's admitted for abdominal hysterectomy. And unfortunately, the patient suffers an intraoperative stroke and is admitted to the neuro ICU and placed on a ventilator. On the 31st, so about 15 days later, the patient spikes the fever to 38.1 degrees Celsius, has elevated WBCs, and has coarse breath sounds throughout. The chest x-rays, however, just show pulmonary edema, but no evidence of pneumonia. The patient does grimace on suprapubic palpation during the assessment. A vaginal exam is performed, and purulent drainage is noted at the vaginal cuff. They do collect cultures from the vaginal cuff, the blood, and the urinary tract, urine cultures. On the 2nd, the final results of the cultures are in. The the urine culture grew nothing, but the blood cultures both grew Acinetobacter baumannii, and a culture of the pus from the vaginal cuff is positive for group B strep. So we have different organisms in the blood than what is collected from the vaginal cuff or the site of infection. So might actually think that this might not be able to say that this is secondary, but let's look at that in more detail. So what's your first feeling? Which of the following is the correct attribution? The patient has a V cuff infection with secondary BSI. Or B, the patient has a laboratory confirmed bloodstream infection. Or C, the patient has both, an LCBI and a surgical site infection, which is a V cuff organ space. And the correct answer is C, they have both. So let's look at why that is. In this case, the patient meets two criteria. for a V cuff. They have purulent drainage from the vaginal cuff on gross anatomic exam, post-hysterectomy. So that's criterion 1. They've met that. And they met that on 131. And they had organisms identified from fluid or tissue from the vaginal cuff. And that is criterion 3, and that was also met on the same date. So in this case, it doesn't matter which one you choose from a date of event standpoint, both dates of event. So they have a primary LCBI with A. baumannii and an SSI V cuff on 131. And again, it's because we do not have a matching blood and vaginal cuff cultures to meet scenario 2, and we don't have, scenario 1, and we don't have a positive blood specimen that can be used as an element of the infection. There is no V cuff criterion that uses positive organisms identified from blood. So in this case, this is an LCBI 1 unless we can find another source of infection to attribute the blood specimen. Case study 3 is another example of where you may have a patient that might meet more than one scenario, or criterion, I should say. In this case, on January 1st, we had a patient that's admitted with abdominal pain and distension. A PIC is placed on the next day. On the 4th, ultrasound-guided drainage of 5 liters of purulent peritoneal fluid is performed, and that peritoneal fluid is positive for club pneumo and E. coli. On January 10th, abdominal pain is increased. The next day, they do a CT scan and identify multiple liver abscesses. They collect some blood cultures, which are positive ×2 for Candida glabrata and Alcaceae. And on the 13th, the patient is jaundice and has fever of 101.2. Again, you get to try your hand. Which of the following is the correct attribution? A, the patient has an LCBI 1. B, she has an SSI, surgical site infection, intra-abdominal infection with secondary BSI. Or C, she has an intra-abdominal infection with a secondary BSI, not a surgical site infection. The correct answer is C again. She has an intra-abdominal infection with secondary BSI. Let's look at why this is. The patient came in and did not have any surgery from the history. They just came in with abdominal pain and distension, and ultrasound-guided drainage was performed, which was positive for the 2 organism, club pneumo and E. coli. And so on that date, the patient actually met IAB criterion 1, which is hospital day 4. Patient had organisms identified from purulent material from the intra-abdominal space. They did say it was purulent peritoneal fluid. Additionally, the patient had, during that same IAB RIT, the patient had abdominal pain, and they did a CAT scan and found that the patient had some liver abscesses, and the patient also had blood cultures with 2 organisms, in this case, that were different from what was identified from the peritoneal fluid. So some individuals will say, there's no way, I can't say that that is secondary because they don't match. But really, as long as you can meet the requirements, and in this case, this patient meets the criterion 3 for fever and jaundice, 2 of the following, he had both of those. He actually also had abdominal pain. And at least one of the following, organisms identified from blood, And it has to be at least one MBI organism, in this case it is, Candida glabrata, and has evidence by imaging test of infection. And in this case, we had a CAT scan that showed liver abscesses. So the patient met criterion 3, and in so doing that, they also met scenario 2 of the secondary BSI rules, meaning that they have a blood culture that's used as an element. So this patient can be deemed to have an IAB3B with a secondary BSI of the organisms here. And those organisms are different in this case from those identified in the other criterion. Because these are both IABs, you would not record 2 separate intra-abdominal infections if you're reporting this. You would instead simply add these organisms onto the first reported event. Moving along, we have case study 4. This is a 45-year-old that has colon cancer who is admitted and undergoes a colectomy. The patient's tunneled central line for hemodialysis is accessed today in the unit. The patient has nausea on January 9th, vomiting, an increase in abdominal pain, and fever of 38.3 degrees Celsius. Blood cultures are collected and are positive for Candida albicans. And the next day, the patient continues to have pain and fever and has 2 episodes of vomiting. A CT scan of the abdomen shows a small bowel obstruction, and the physician documents that the source of the positive blood cultures is the gastrointestinal tract. So what do you think? Which definition should be applied in this case? Should we be looking at the gastrointestinal tract infection, or GIT, the intra-abdominal infection, the other reproductive infection, or OREP, or none, because this is the primary BSI? The correct answer is that we should be looking to GIT, and why is that? This is something that sometimes infection preventionists have a little bit of trouble understanding, so we want to make sure that it's clear. In this case, this patient has colon cancer and has a small bowel obstruction, and the physician notes that there's a GI tract source. Our gastrointestinal tract infection definition includes the esophagus, the stomach, the small and large bowel, and the rectum. And then we have guidance that says that it excludes gastroenteritis, appendicitis, and C. difficile infection. So really what's included here is the lumen of the intestinal tract. It's the inside of the intestinal tract. That's in contrast to the intra-abdominal infection, which includes the gallbladder, the bile ducts, the liver, the spleen, pancreas, peritoneum, retroperitoneal, or subphrenic or subdiaphragmatic space, or other intra-abdominal tissue or area not specified elsewhere. So we're really looking inside of the intra-abdominal cavity here for infections. We also have the option of the OREP definition, and that's one that's not always thought about by infection preventionists, but it should be if the infection is involving the deep pelvic tissue or infection of the male or female reproductive tract, the epididymis, the testes, the prostate, vagina, ovaries, or uterus. It does include chorioamnionitis, but it excludes vaginitis, endometritis, or vaginal cuff infections. We have a separate vaginal cuff infection definition, as we mentioned earlier. So in this case, what we're really looking at is the gastrointestinal tract, because it didn't involve the intra-abdominal space or the deep pelvic tissue. Oops, went backwards. But does the patient meet criteria? So let's look at the GIT. In this case, the patient doesn't really end up meeting any of the criteria, and this ends up being a primary LCBI 1, a CLABSI, with Candida albicans on January 9th. And we've highlighted here, what are met. We did have an organism in the blood for criterion 1, but we didn't have evidence of an abscess or gastrointestinal tract in any way. The notation by the physician that he believes it's the source of the infection is not enough. We have to actually have evidence of infection. And the patient also doesn't meet 2. Again, we had organisms, we did not have organisms identified from drainage. We had some of the symptoms that were required, but we did not have the imaging test that was needed to go along with the positive blood specimen. Okay, case study 5. We have a 41-year-old female that's been on your unit for 2 weeks on February 14th. She has a central line through which she has been receiving hemodialysis since admission. On the 17th, her central line insertion site is red and has purulent drainage, which is cultured and positive for Pseudomonas aeruginosa. She develops fever of 39 degrees Celsius and shaking chills on the 19th, and 2 sets of blood cultures are sent. On the 21st, her blood culture results are positive for Pseudomonas aeruginosa. This is probably a scenario that you've all run into. So your questions are, is this an LCBI? Your question is this an LCBI? And your choices are, yes, the patient has a laboratory-confirmed bloodstream infection with Pseudomonas aeruginosa. No, the patient has a skin infection with Pseudomonas aeruginosa and a secondary BSI with the same organism. Or no, the patient has a VASC infection with Pseudomonas aeruginosa and a secondary BSI with the same organism. And the correct answer here is A, patient has an LCBI. So let's look at why this is. In short, the infection will not be considered a skin infection if a vascular access site is involved. And it will either be a vascular infection, or VASC, or it would be an LCBI in the cases where there's also a positive blood specimen. And you'll note that the skin infection criterion here has, under the reporting instructions, report a localized infection at a vascular access site as a VASC, unless there is an organism identified from blood meeting the LCBI criteria, which should instead be reported as an LCBI. And that's the case that we have here. Let's look at the VASC criteria. You'll note that we have right underneath the VASC definition or description, which is arterial or venous infection, we have, note, if a patient meets the criteria for an LCBI, in the presence of an intravascular infection, report as an LCBI, not as a VASC. And then there is also, under the VASC infection criteria, another reporting instruction that mentions the case where you have both pus at the insertion site and a culture of that pus that's collected during the LCBI infection window period matches at least one organism in the blood specimen, that can be considered not a central line associated bloodstream infection if a central line is involved. And then a list of devices is included for the exception. But you'll notice that the one that involves a central line requires that central line not have been accessed nor inserted during the hospitalization. And in this case, we said that the central line had been accessed. So in short, the best way to think about this is that in this case, there is an infection at an eligible central line site, which caused a bloodstream infection. And therefore, we would want to collect that and to recognize that that is a central line associated bloodstream infection, rather than call that a vascular infection. Our prevention efforts at both insertion and maintenance should be effective in some way to help try to prevent these types of infections. Okay, we're getting close. We've done quite a few studies. We have just a couple more. We have case study 6, in which a patient is admitted to the PICU 4 months status post-allogeneic stem cell transplant for acute myeloid leukemia. A port was in place and was accessed on the date of admission. Her current weight is 25 kilograms. On the 8th, the patient becomes disoriented and hypotensive, and 2 sets of blood are collected for culture. Both are resulted as positive for Enterococcus faecium. On the 9th, the patient complains of nausea, emesis, diarrhea, and abdominal pain. And on the 10th, she's diagnosed with grade 3 graft versus host disease by an endoscopy. Your question, true or false? This BSI is secondary to GIT and therefore is not an LCBI. You can say true or you can say false. This is an LCBI. It's actually a mucosal barrier injury LCBI. The correct answer is B. This is actually an MBI LCBI. And here's the rationale for this. The GIT criteria reads that the patient has at least 2 of the following signs or symptoms compatible with infection of the organ or tissue involved. In this case, it's fever, nausea, vomiting, pain or tenderness, odynophagia or dysphagia. And you'll notice that all but fever have an asterisk after them. And that asterisk is related to the statement with no other recognized cause. In this case, the patient had 3 of them. He had nausea, vomiting, and pain. And the patient has to also have at least one of the following, one of which is organisms identified from blood, and that it has to be an MBI organism. And in this case, that is true. The organism involved, which I've forgotten already, which is Enterococcus faecium, is actually an MBI organism. And the patient also has to have imaging test evidence suggestive of gastrointestinal infection, and we did not have that. We had evidence of graft versus host disease by endoscopy, but not of infection. So, as you'll recall, before a patient can meet the MBI LCBI criteria, they have to first meet the LCBI criteria, which includes, again, determining that the BSI is not related to an infection at another site. The patient did not meet the GIT criteria because the infection was not identified by an imaging test. And additionally, graft versus host disease, neutropenia, and chemotherapy can cause symptoms such as nausea, vomiting, and abdominal pain. And so we would, in most cases, say that those symptoms should be excluded in cases such as this. So the MBI LCBI criterion, patient meet criterion 1, which they did. It was an MBI organism, and in this case, the patient is an allogeneic hematopoietic stem cell transplant within the past year, and had grade 3 or 4 GI GVHD documented. One final pearl of wisdom regarding the GE criteria, and those criteria mention an enteric pathogen being identified from stool or rectal swab. Examples of enteric pathogens include things that you would normally think about, such as Campylobacter, Shigella, any of the enterohemorrhagic E. coli or enteropathogenic E. coli, Salmonella, Listeria, Yersinia, Vibrio, and Giardia. It does not include organisms such as Enterococcus and Pseudomonas. Those organisms, although they're found in the gut, that's true, they're also very important environmental pathogens and not ones that we think of as causing, for the most part, gastroenteritis. So in summary, before we do just a couple of more case studies that were put together for some small group work, there are only two ways to make a secondary BSI determination. Scenario 1, as we said, where there is a site-specific specimen that's used to meet the criteria, and then we have a blood specimen that has at least one matching organism and is collected during the secondary BSI attribution period. Or scenario 2, where having identified an organism in the blood specimen is actually used itself as an element to meet that infection criteria. And therefore, because it's an element, it has to be collected in the infection window period for that infection. If neither of those scenarios are met, it has to be considered a primary BSI. The only exception that we have is the NEC criteria, whereby as long as a criteria for NEC is met, an organism identified from the blood during that SBAP is considered secondary. Sometimes blood cultures or organisms that are identified in the blood during the present on admission time frame will need to be investigated because you'll have a subsequent bloodstream infection, and you need to determine whether or not that first BSI was primary or secondary so you can determine whether or not a BSI RIT was set. If it's secondary, then that second BSI will certainly have to be investigated, and whereas if the first BSI was primary in nature, it would set a BSI RIT, and you would only have to do an investigation after that 14-day period has passed. Blood specimens that occur in the SBAP have to contain at least one matching organism to the site-specific specimen, and that specimen had to have been used to meet the definition initially. Otherwise, you're going to have to investigate it as being either primary or secondary in nature. And remember that sometimes a patient will meet more than one criterion for a type of infection, and if that occurs, you need to consider all of the potential infection window periods to identify another possible criterion that can account for that bloodstream infection as secondary. So look at all of the criteria that are available to you. Remember the tools that we have provided to you. They're all valuable, and they can help understand your understanding of the HAI surveillance. Okay, we're in the home stretch. We're going to do two final case studies looking at secondary BSIs. These are a little challenging on purpose, and unfortunately, the reality is that you are faced with challenging cases all the time. So we have to address those scenarios as well. So case number 1. In this scenario, we have a patient that's admitted on January 7th. Patient has a history of bradycardia and had a pacemaker placed in 2016. On February 4th, the patient has a positive blood culture, actually 2, for Enterococcus faecium, 1 positive on the 5th for the same organism, another 2 collected on February 6th, positive again for E. faecium. On 2/7, another single positive blood culture for E. faecium. On the 12th, they've placed a PICC line, a peripherally inserted central catheter. On the 16th, the patient has another blood culture that's collected, and this time it's positive. One of them is positive for Staph aureus. And on the 22nd, they are investigating this, and they note that there is a vegetation on a pacemaker lead that they collect a specimen from and send for culture, and that is positive for Candida albicans. And on the 25th, we now have a positive blood culture for Candida albicans. So as I said, this is a little bit complicated case history, but not all that unusual. So we have a series of 4 questions to consider. Number 1, which infection definition should be used in this case? Number 2, is this a primary or secondary bloodstream infection? Number 3, which event creates a BSI-RIT? A primary BSI, a secondary BSI, or both? And what is the final determination for this case? So let's look at the answers. The definition that should be considered in this case, given the positive vegetation on the pacemaker lead and the blood cultures, is endocarditis. And as far as whether this is a primary or secondary BSI, it really depends on which one you're talking about, 2.4 or 2.22. We'll look at that. And which event creates a BSI-RIT? Of course, only primary BSIs create a BSI-RIT, and therefore in this case, that would be the 2.4 BSI, and we'll talk about why that is. And then let's look at what the final determination is for the case. Now we need to remember a few things as we talk about endocarditis and the definition in NHSN. Endocarditis has a longer infection window period. It actually, instead of having a 7-day infection window period, has a 21-day period. That includes the day of the diagnostic test, 10 days before and 10 days after. And the reason for that is that it does sometimes take a period of time before the picture is complete enough that the suspicion of endocarditis arises, or that all of the requirements for making the determination can be performed. Likewise, there's an extended secondary BSI attribution period for endo, and that includes the 21-day infection window period and all subsequent days of that patient's current admission. And this is to recognize that endocarditis is sometimes very slow to resolve, that multiple blood cultures are often collected during the patient's admission in order to determine the effectiveness of the treatment, which can be lengthy, and not wanting facilities to have to report multiple eclampsies in a patient that actually has endocarditis. There is one caveat to that, and that is that the secondary BSI attribution period is limited to the organisms that are identified in the blood specimen that match the organisms used to meet the endo definition. And what do we mean by this? We don't expect that a patient coming in with endocarditis with one organism during their admission are going to have other organisms be recovered from that endocarditis. Now, the scenario that comes to mind that might be the exception of that is a patient that is accessing their own IV line for illicit purposes. in which case you may very well have polymicrobial blood cultures in that patient. But we have accounted for that scenario in the BSI chapter related to making an exclusion for patients that are accessing their line. So I would refer you to the BSI chapter to look into that and the time period that is related to that. So in this case, there are no other elements present during an endo infection window period set by the 2-4 BSI. So using the blood specimen on 2-4, that would give us an infection window period of 21 days of 125 through 214. And we don't have any other elements during that time to fulfill the endo criterion. And as long as no other type of infection is suggested and criteria met, that means that this would be a primary BSI. So in that case, we would have a primary BSI with the organism of E. faecium on 2-4. But this patient had multiple blood cultures collected, as they will in these types of cases. So now we need to consider the next positive blood culture that is, this is outside of the BSI RIT, and that's true in this case because all of the other blood specimens that are collected within the BSI RIT are of the same organism. We don't have, a E. faecium collected on 2-4 and then a Staph aureus collected on, and actually, I'm sorry, let me take that back. Because we set a BSI RIT, it doesn't matter what the organisms are. In this case, it ends up being that they are all the same organisms that are identified, but that's not required. Actually, we have 216, we have a Staph aureus, so that gets rolled up into the BSI RIT from the 2-4 blood culture. But now we need to look to the 225 blood culture, which has not been accounted for with Candida albicans. So we had a pacemaker lead that had vegetation and a culture on 222, and that culture was positive for Candida albicans, and that is going to set a potential endo infection window period of 212 through 34. Again, 21 days. So let's look at this graphically. We have here on the left-hand side, we've accounted for all of the blood cultures from 2-4 through 216, the repeat infection time frame, as we identified, is 214 through 217, because this is a BSI RIT. And because this is a BSI RIT, during that RIT, you don't have to investigate any other positive blood specimens. You simply roll those up and consider this a primary LCBI of, with both E. faecium and Staph aureus, date of event 2-4. And in this case, because the culture wasn't collected until day 4 of hospitalization, this is categorized as a healthcare-associated BSI. Then we have a period of time where we don't have any blood cultures collected, but we have another blood culture collected on 225, which is outside of the BSI RIT said earlier, so we have to investigate it. And in this case, the patient met endocriterion 1 with Candida albicans on 222 because they had a positive lead of vegetation and positive blood culture, and so this is a secondary BSI to endocriterion 1. Our second and last small group case study is case 2. In this scenario, we have a patient that is admitted on 2-2 with fever and chills of unknown origin. The patient's knee has been sore the last few days, but there is no obvious specific symptoms. On the 8th, we do have some symptoms. The knee is actually drained of fluid, sent for culture, which grew Staph aureus. On the 14th, patient continues to have increased pain of the left knee. He's not able to bend it because it's swollen. On the 17th, we have a positive blood specimen for Staph aureus. On the 22nd, we have another positive blood specimen with Staph aureus and strep pneumo. And on the 24th, we have another positive blood specimen with strep pneumo and Neisseria gonorrhea. So your two questions are, which definition should be used in this case, and what is the final determination for the case? So this patient actually meets, again, as we've seen before, he actually meets two criteria for joint, which is JNT or joint or bursa infection. The patient meets criterion 1 with organisms identified from the joint fluid. And the patient actually also meets criterion 3, which involves 2 symptoms. And the patient has 2 of those symptoms, swelling, pain, actually 3, and limitation of motion, all in the IWP. And patient has organisms, this should be 3C, organisms identified from blood by culture or non-culture-based micro-testing. Sometimes those, when we work on these slides, those little circles get shifted, and so that should be C. Make that, if you'll make that note. So let's look at this determination. This patient has an increased left knee pain on the 14th, is unable to bend it due to swelling, and the patient has a positive blood culture on the 17th. That positive blood culture will set the infection window period, 3 days before and 3 days after, and that is enough to meet the joint 3C criteria with Staph aureus. Now, during the secondary BSI attribution period, the patient has another blood culture collected on the 22nd, which has Staph aureus and strep pneumo. And because there is a matching organism, the Staph aureus, to the blood that was used to meet joint 3C criterion, we're simply going to add on the strep pneumo to that determination. So a joint infection on 214 with Staph aureus and strep pneumo. But we have another blood culture that was collected on the 24th that we have to investigate because it has another organism in it, Neisseria gonorrhea. And neither the strep pneumo nor the Neisseria gonorrhea were included in this blood culture here that was used to meet this criterion. And as a result, we cannot say that this BSI is secondary to the joint infection. We do not have a matching organism to the specimen that was used to meet the criterion. So we would have to investigate this blood culture to determine whether or not there was another potential secondary site of infection. If we cannot find that other, I should say primary site of infection. If we cannot find that criterion, then that infection would have to be considered a primary BSI. That concludes the presentation today. I want commend you for sticking with us, and hopefully you've worked through all of the case studies that we presented. And as always, if you have questions for us, you can email us at nhsn@cdc.gov, and we'll be happy to answer those questions for you. Great job